Welcome to Module 1, Biological Models for Suicide Prevention course. My name is Paul Demita. I'm a holistic nutritionist who's passionate about the orthomolecular approach to supporting mental health. Suicide prevention is an important and timely topic, and I am honored to introduce this webinar on behalf of the International Society for Orthomolecular Medicine. The International Society for Orthomolecular Medicine is a not-for-profit organization whose purpose is to advance education, communication, and advocacy for medicine throughout the world. The term orthomolecular was coined in 1968 by two-time Nobel laureate Linus Pauling. Orthomolecular medicine is the practice of using substances which are natural to the body in optimal amounts to prevent and treat disease. Orthomolecular substances include vitamins and minerals and other micronutrients. Linus Pauling proposed that mental abnormalities could be treated by correcting imbalances or deficiencies in naturally occurring biochemical brain components. He proposed treating with orthomolecular molecules instead of potent synthetic psychoactive drugs. The concepts presented in this course align with orthomolecular and integrative approaches to health and medicine. Biological Models for Suicide Prevention course is a three-part webinar series developed to support improved outcomes in suicide prevention. This first module will focus on understanding suicide prevention from an orthomolecular perspective. The subsequent modules will address risk factors and the role of inflammation in suicidality and nutritional interventions for suicide prevention. Registering for this course provides you with on-demand access to the recordings of all three modules, a printable course manual in PDF format, and a certificate of completion. This course is being presented by Dr. James Greenblatt. Dr. Greenblatt is widely acknowledged as one of the leading clinicians and educators in the field of integrative psychiatry. He has been treating patients with complex behavioral and mood disorders since 1990. Dr. Greenblatt completed a 2-year fellowship at Johns Hopkins University School of Medicine to become board certified in child and adolescent psychiatry. He has written numerous books on the treatment of anorexia, attention deficit hyperactivity disorder, and depression. He currently serves as Chief Medical Officer at Walden Behavioral Care in Waltham, Massachusetts, and as Assistant Clinical Professor of Psychiatry at the Tufts University School of Medicine and Dartmouth College Geisel School of Medicine. Additional information about Dr. Greenblatt, including a list of his books and courses, can be found online at jamesgreenblattmd.com. At the conclusion of this presentation, there will be an opportunity to ask questions. You can do that by typing your questions in the control panel on the GoToWebinar page. And now to Dr. Greenblatt.
Great, thank you, Paul. And it's a very difficult conversation, a difficult topic, but I think it's just so important that as clinicians, as educators, as citizens, that we kind of relook at suicide and suicide prevention, and an orthomolecular approach, as Paul described, is trying to understand some biological perspective. And that's what I hope to share with you over these next 3 modules, a biological model of prevention, evidence-based, with hundreds of research articles that we need to get our doctors to better understand. So I guess I'll contrast my model with what we're currently doing as a suicide prevention modality. So I think everyone here will recognize the Golden Gate Bridge. It is a major place for suicides with numerous individuals jumping from this bridge. What you see on the left here is a net. It's a schematic drawing, architectural drawing of what is just approved by the city of San Francisco as a deterrent for suicide. What you see on the left of the Golden Gate Bridge is a metal net. It is a $250 million construction project to prevent suicide. And the prevention model here is a deterrent. So if someone is standing on the bridge, they will see a metal net. They will not die, they will hurt themselves. And the goal is that they will not jump into this metal net. Now, there's actually some research. There are metal nets around the world in other countries. I think China has one, the Netherlands, and it does deter people jumping from that particular spot. It does not decrease suicide rates. $250 million. In one of my psychiatric journals, there was a debate, two psychiatrists talking about the pros and cons of this project. One psychiatrist said, wait a minute, $250 million for the city of San Francisco. We could get every high-risk person weekly psychotherapy and medication and likely do a better job of preventing suicide. The other person discussed, well, since that's never going to happen, we don't have the mental health system in this country, might as well build a net and have a deterrent. So my premise is the biological model, the orthomolecular approach, looking at the science of what's happening in the brain of those that think and commit suicide is a better model than a metal net. There's just a frighteningly increase in what we're experiencing in the arts and TV and the movies and the theater on suicide. It's somehow easier to talk about if it's somewhat distant from ourselves, but it's just becoming increasingly common. I don't know anyone who's seen A Million Little Things, but I watched it by accident, the first episode, and the gentleman with the tie in the middle was jumping off his balcony for suicide, and the gentleman on the right, the African American, was taking a bottle of pills at the same time in a suicide attempt. And the entire show is based on unraveling his suicide. And then obviously A Star is Born is suicide. We keep going to the last two Tony Award winning musicals. Dear Evan Hansen, the whole theme is about adolescent suicide. Dan's Visit, the next year's Tony Award musical, one of the lead's son committed suicide. And our culture kind of woke up, as two celebrities. Anthony Bourdain and Kate Spade obviously became headlines, both having histories of depression and suicides with both young children that they loved, and it was a shock to all. What has happened is more awareness, but again, the model hasn't changed. I'm going to go through some of these slides quickly, but rising suicide rates are just now commonplace as the research came out looking at these 15-year studies, 25 to 30% increase, with 25 varying by state. 25 states had almost 30%. We used to think, or at least when I was in training, that you don't commit suicide unless you're over 15 or 16. If a 12-year-old threatens suicide, we wouldn't take it seriously. But now there's also an epidemic of preteen suicides. The increased suicide rate of girls 10 to 14 years of age in this 15-year period, 99 to 2014, was 200%. 10 to 14-year-old girls, 200%. Some of the recent headlines that we'll talk about later are some of the preteen suicide. We worry every day about homicides because that gets on the front page of the news, and it is a primitive fear, but it's just really dramatic when you put it in perspective. More than twice as many suicides as homicides. And our little clock, our stopwatch there, by next year, by 2020, there'll be a suicide globally every 20 seconds. Think about the number of suicides that have occurred just in the 5 minutes I've been talking in the course of a day. Every 20 seconds, this is globally, for the year 2020, there'll be a completed suicide. So again, more so after our celebrity suicides, there is intense awareness and significant prevention outreach. Some of these are on the state level, some of these on the national level, but there are suicide prevention trainings, suicide prevention toolkits, um, and much of these are training educators and professionals. And one of the more interesting is looking at tweets and looking at analyzing tweeting, and also there's a texting program, and some of the certainly Good Samaritans here in Massachusetts have a very robust social media intervention and detection. So we, meaning the medical community, the public health initiatives are trying. And part of what I kind of want to share with is that we can do a better job. So our screening and assessment tools, it's based on research and clinical uh, knowledge, and we know that there are a list of risk factors, and trauma and substance abuse, past attempts, financial stress. Actually, faith here is a protective factor, so we have risk factors and protective factors. We know age, um, elderly men, support systems, those that are alone, medical issues, recent medical diagnoses, suicidal ideation plans, and pretty dramatic shifts with access to guns. So these are the kinds of things that we would ask a patient who gets to a hospital or gets to a crisis center, and here we can assess risk. But the model that I want to share with you over the next 3 hours or 3 modules is there a kind of a way of trying to identify not just risk, like who's going to be more, um, if you will, at risk to, let's see if I can use a pen here, who's going to be more at risk to complete suicide. So this is the area, because suicidal ideation is common, particularly in my world, in mental health professional. Suicide attempts are common in terms of getting to psychiatric hospitals or treatment, but there's a very different concept of who actually completes suicide, and the model that I want to share with you is, I believe that we have a model of who's biologically more at risk. Here, 2,500 individuals, suicidal ideation, predictors for mental health, substance abuse, and difficulty getting treatment. So part of the problem is our psychiatric kind of model. Our general medical model is somebody is sick. Let's say you have a cough. Your doctor is going to measure those symptoms. So what are we going to do to measure the physiology? We can do an X-ray, right? We can do blood tests. We can do a CAT scan. We can do all these things to find out what's going on. And for that cough, there's going to be a different treatment for a pneumonia that's viral, for a lung cancer, or for a abdominal or metastases. So there's different treatment based on the physiology. And then let's say you have pneumonia, we're going to give you an antibiotic, and then we're going to recheck and measure, make sure everything's okay. So that's our medical treatment. And one of the reasons we've gotten in so much problem in all of psychiatry, and particularly in our assessment and treatment of suicide, is what do we do after somebody presents with symptoms? Let's just take depression. All we can do is give an anti-symptom treatment. So if you're depressed, right? So those are the symptoms. You're sad. There's no concept of, in traditional psychiatry, looking at why. We're just going to give you an antidepressant, right? So you could be sad because you're anemic. If it's our case of somebody with very low iron, you could be hypothyroid, you could be B12 deficient, you could have trauma, flashbacks. I mean, the list in my whole career is based on trying to understand what are some of the root causes of depression. But our model is just anti-symptom treatment. We can take the same for anxiety, anti-anxiety medicine. And all we can do is ask how you're feeling. So there's no model of looking at that anti-physiology treatment. And I do believe, my world changed 16 years ago when I got into this field of eating disorders and was able to integrate my passions of nutrition and brain function and nutritional relationship to mental illness. And as I kind of got immersed in the world of anorexia nervosa, which is a disorder of both starvation and delusional thought processes, it was quite clear to me that high rates of suicide were related to the malnutrition. So patients with anorexia, 31 times more likely to commit suicide than the general population, and more than half of the anorexic deaths are a result of suicide, not what we think medical complications of starvation or cardiac risk or electrolyte abnormality. More than half of the deaths are suicide. And then we have to just go back to kind of the big picture. Anorexia nervosa has the highest mortality rate of any psychiatric illness and the highest risk of suicide. So that's where my thinking started 16 years ago. One, for 15 years as an adolescent psychiatry on inpatient psychiatric unit, I was never exposed to a completed suicide. It was that diagram I showed you where there were suicide ideation and attempts. We treated them, and I had no experience of a completed suicide. Since I've been working with eating disorders, there are 30, 40, likely more individuals that have come across our treatment program that eventually have committed suicide. And they commit suicide usually when the people around them think they have recovered. So that has been kind of my model or mantra to try to understand these very, very high rates of suicide in this population. And I believe we can kind of extrapolate that to a general population as we understand it. And here's the model that we'll go through in these 3 modules. Tonight, I'm going to talk about medications and trauma and genetics. And the bulk of this course will be on understanding nutritional deficiencies, inflammation, sleep deprivation, and lithium as how it develops as biological risk factors. So let's start tonight with medications. And, we have this polypharmacy highway. The vast majority of patients are taking psychotropic medications. I forget the statistics of, I think it's over 2/3 are taking more than 3 psychotropic medications. We have this polypharmacy highway. You can see all the way down there, Xanax at the bottom, and then these boxes in front. We're not doing a great job. 40% relapse, 20% incapacitated or suicide, and the most striking is 66% with residual symptoms, even after we say the depression is better, or the research paper says the depression is better. Our adolescent results are even more abysmal. 1 out of 14 medications studied were effective for depression. So very, very poor research that's chaining. And just think about it for a minute. We provide a patient with antidepressant medications. They're coming in depressed and maybe suicidal. And we're telling them the major side effects are going to be no libido, weight gain, and a risk of suicide. How do we share with a parent and how do we ask them to make a decision for their 16-year-old depressed child who committed suicide after school and brought to the psychiatrist? Well, we have this medication that might um, exacerbate suicidal ideation. So that's where I want to start this kind of controversy of medications and suicide. And I do want to share with you that for the first 15 years I was in practice, during this 204, when the black box warning came out from the FDA that antidepressant medications can increase suicidal ideation. Again, I was working in a very busy psychiatric hospital, seeing lots of kids, and I never had seen this exacerbation. And so it didn't quite make sense to me. And then I came and started working in an eating disorder facility. And I started seeing intense suicidal ideation in patients with eating disorders. They started an SSRI. There was a children's hospital in Boston that put all of the patients with eating disorders, anorexia, on SSRI. Now they don't do it anymore, thankfully, but that's what they did, 14 years ago. We would see them 2 or 3 weeks later. They were intensely suicidal. The kids got scared. They didn't understand it. They weren't suicidal before. The parents didn't understand it. Stopped the antidepressants. The suicide went away. These are just some of the kids I've seen from, 7 to 16. And what is important, particularly anybody that works with eating disorder patients, is the suicidal ideation are individuals that are close to normal body weight. So you don't have to, it's not a low body weight phenomenon. It is an eating disorder phenomenon, but certainly this is just a 10-year-old kid who's put on Prozac and very aggressive thoughts of suicide and self-harm. A 16-year-old put on Cymbalta, no previous history, suicidal ideation within 1 week. A 14-year-old put on Prozac, suicidal ideation. So it happens. I see it all the time now. It's not just on weight, but what is it? And as we start to understand, and that's what I kind of want to share with you, dose is important. This is 162,000 individuals and 2014 patients under 24. The higher dose is twice the risk of suicidal behavior. So, and we often see doctors prescribing very high dosages. I just I did a consult on a 9-year-old boy on 200 milligrams of Zoloft. He's really agitated. So I'm not quite sure where these doses come from, but dosage is important. I would start any young individual at very, very low dosages. And this was the study that I just want to take a few minutes to talk about. This was the original Paxil study for depression, published in the American Journal of Child Psychiatry, and this was individuals who the original study showed a improvement in mood, and prescriptions of Paxil went up 36% after the study was published in 2002. So in 2015, the British Medical Journal took the study, took the data from the original study, published in the American Journal of Child Psychiatry in 2002, and they just looked at the data and reanalyzed it. And they published that not only it was unsafe, they called it the Restoring Study 329, they showed that original study had um, 11 individuals in the Paxil group engaged in suicidal behavior versus only one individual in the placebo group. Serious side effects such as suicidal tendencies were mislabeled and misrepresented in the original study. So a retraction, um, but it just points to a couple things that I'm very sensitive to. Is manipulation of data can be um, done in any fashion that you like, because most people reading the studies are not statistical experts, and these medications do cause increase in suicidal ideation. The most helpful study that I have found when I both teach and clinically in my experience, published a number of years ago, is almost 160 users of 4 antidepressants. What was found, in my experience as well, is the vast majority of individuals that have this intrusive thought, this intense suicidal ideation on these medicines, it occurs early onset in treatment. Usually within the first 30 days. But here you see non-fatal suicidal behavior 4 times more likely to occur within less than 10 days, and then 3 times more likely to occur under 30 days. So it's really important that we monitor, if we put someone on an antidepressant, or we know someone is taking an antidepressant, that we monitor closely, particularly our eating disorder patients or our malnourished patients, because those first 30 days is what's most important. So if someone develops suicidal ideation 6 or 8 months out, oftentimes I don't necessarily correlate that with a medication side effect. So those first 30 days. But in our community mental health clinics, even in our suburbs, where we can't get appointments with child psychiatrists, or even other psychiatrists might say, come back in 3 months, handing prescriptions of Prozac or SSRIs. I believe this is both dangerous and concerning because these kids are struggling. It's hard for the individual patient to understand what's the medicine, what's the exacerbation of their symptoms. It's certainly a struggle for the parents to understand it, and a mental health professional needs to evaluate these kids within those first 30 days to understand. When you see it and you hear it, and you listen to the patients, it is a intrusive thought, similar to an obsessive thought, an intrusive thought, wanting to die, that feels uncomfortable. The medication side effect story is really endless and kind of complicated by, anti-psychiatry groups, but, the list is pretty endless of some of our violent, aggressive um, uh, school shootings associated with psychotropic medications. Um, these are school shootings, the dates, the years, and where the medications. Lots of SSRIs. Now, it doesn't necessarily say X caused Y, but I think it's concerning enough, and we've seen it enough. It's got a black box FDA warning. That is not necessarily an easy task, so we need to understand and ask the question. Okay, so it's not just the SSRIs. Multiple medications that we are prescribing both our children and our patients, and that we take, are associated with increased suicide risk. Let me just start with a couple. Accutane. This was an email that I received within the last couple months. Accutane has destroyed my son's life. Two of the young people I know are on the verge of suicide. Accutane also has this warning of suicide. And I think when it first came out, we were concerned, and I believe based on the patients that I'm seeing being put on Accutane, major psychiatric concerns that aren't being monitored or addressed. Doesn't mean everyone on Accutane is suicidal, and that's our whole concept that Paul described of understanding orthomolecular medicine and biochemical individuality. Everybody is different, and we need to assess those differences. We talked about the antidepressants. Now all the anticonvulsants, again, our mood stabilizers, our anti-convulsant mood stabilizers also have black box warning for suicide risk. And then, interferon C is used for both cancer, MS. We're injecting this, and we had a patient a couple of years ago who got so suicidal after injections of interferon C that she was hospitalized in our inpatient psychiatric unit prior to the injection. So interferon C is injecting these inflammatory agents that increase risk of suicide. And then Chantix or anti-smoking also increase risk of suicide. We see the commercials. We listen to it every day we're watching TV because they all say risk of suicide, but we're just kind of immune to it and don't address it. And there are more medications. There are a couple of studies that have come out on steroids, glucocorticoids, and suicidality, looking at here 18 years, increased risk of suicidal behavior. So medications are a concern. I just kind of really enjoy this concept and this quote because it's such a core of the work that I do, because it's very hard to base everything that I do as a psychiatrist in the world of mental illness on clinical trials based on this concept of biochemical individuality. Even if the clinical research could match the demographics of study to those of the likely users, no group of trial volunteers could ever match the extraordinary biological diversity of the drug's eventual consumer. So again, not every patient who takes an SSRI will become suicidal. There's some biological risk factors that will help us understand that. We're going to discuss many of those today. One, of course, one that we're not going to talk about, though, is B12 deficiency. And I believe that is one of those risk factors that is associated with agitation and increased suicidal ideation. So, I don't know, pretty tremendous number of prescriptions, 12 scripts per individual in the U.S. is a little scary and, do no harm. So medication, first 30 days for the antidepressants, we need to ask the questions, we need to think about it. If we have a high-risk kid, our first kind of understanding is what medications are they taking, and careful as to what medications we're going to prescribe. So the next kind of biological phenomenon that we need to really understand is trauma and risk of suicide. And here we're talking about physical trauma to the brain as well as psychological and emotional trauma. And, it's kind of a sad reality that it took so long to understand if we bang up the brain long enough that there would be neurobehavioral implications, chronic traumatic encephalopathy, CTE, kind of now major motion picture, major concern, absolutely no cure like Alzheimer's, and all significant major players that have went on to kill themselves and hurt other people. Unlike Alzheimer's disease, CTE is similar. There's inflammation, and there's also the plaques and tangles. But chronic traumatic encephalopathy, distinguished where the plaques and tangles around the blood vessels and the cortical sulci knot in the synapses. A new concussion narrative has emerged, and it's arguably more disturbing. Externalized rage, players becoming aggressive and violent in middle age, liable to lash out at their loved ones verbally and physically. Again, more CTE and murder and suicide. So, CTE is more common in some of our professional athletes, but now there's growing research. We're seeing more. We have some 2018 studies. Just head injury, traumatic brain injury, car accidents, bicycle accidents, concussions, soccer, football. So traumatic brain injury, individuals have 3 times more likely to die from suicide. Here's 218,000 individuals, age-matched controls, looking at mortality rates. And here, they were able to look at severity of the traumatic brain injury. And this and other studies that the severity is not always a factor. Here's a retrospective study, 7.4 million individuals. The studies that I have found, we just have a few here tonight, it's anywhere from 2 to some 4 times increased suicide risk with traumatic brain injury. So here, 7.4 million people in medical contact for TBI, 2-fold increase in suicide. Denmark, 7.4 million subjects over 10. And the elevated risk, this is what I mentioned earlier, this is Journal of the American Medical Association 2018, the elevated risk across all levels of severity. And then Journal of Neurology, concussion or mild traumatic brain injury associated with 2-fold higher risk of suicide. Again, November 12th, 2018. We're talking about a few months ago, published. Over 700,000 patients. Think of our children. I can't tell you how many times one of my daughter's friends is home because of a concussion, or patients that we've seen, the soccer, the football, the multiple sport concussions. 2 times higher risk of suicide. So, I'm not on the soccer field, but I did want to kind of share that injury to the brain, trauma to the brain does dramatically increase suicide. My world is the emotional, the sexual trauma and neglect that fills our mental health clinics and hospitals, and has a clear, dramatic relationship between suicide. So adults, 64% of suicide attempts among adults were attributable to trauma. 80% of suicide attempts among kids and teens attributable to trauma. I mean, these are huge numbers. In my experience, it might be low estimate. So if we just dissect that a little bit, a study in the Netherlands, 4,800 kids fall for 3 years, childhood abuse, multiple adversity, associated with future suicidal behavior. If we look back, 1/3 of adults who were physically abused in childhood, so 1/3 seriously considered taking their own life. The rate is 5 times higher than adults who were not physically abused in childhood. The I did one of the hardest parts of my career is I spent a year and a half doing evaluations for the Catholic, for a lawyer, Garabedian, for the victims of the Catholic Church sexual abuse scandal. And what was so striking in these hundreds of evaluations that I did, oftentimes many of these individuals did not remember the trauma, the sexual abuse from the priests. Most of the repressed memories were with men, some were with women. And until they were older, 30s or 40s, and many of them remembered only when they watched TV and they saw some of the abuse scandal unfolding and they saw the priests that abused them, they started having flashbacks. And some of these stories were so identical over the course of 6 months or a year, more depression, anxiety, and then a couple of serious suicide attempts without any prior history. So when we look at some of these studies of childhood trauma and abuse and compare it to suicidal attempts, I think it really underestimates, because lots of our trauma victims are not acknowledging the trauma. When we think of the mechanism, one of the things that is now kind of overtaking the field of psychiatry and neuropsychiatry is this concept of inflammation, a neuroinflammation affecting depression, and we now understand inflammation affects suicide risk. And one of the neurophysiological consequences, if you will, of childhood maltreatment, childhood abuse, that it affects the immune system. And these individuals are more likely to suffer chronic inflammation. So they have inflammatory markers as adults, even though the trauma occurred when they were children. So there are numerous studies looking at inflammatory markers, C-reactive protein, elevations of certain cytokines, which are all markers of inflammation. And we have the research to demonstrate that those, if they're elevated markers of inflammation increase suicide risk. So in our biological checklist that we're going to go through over these 3 hours, we're asking about medication, we're asking about trauma, and we now have a tool we can look for measures of inflammation. I didn't put all the research, but it's quite significant. Inflammatory markers, simple blood tests predict suicide. The kinds of trauma associated, all are profound in terms of suicide and trauma. As growing up, we thought bullying was bad, but it was just not having the profound implications that we're now understanding. And I just kind of reread a case here in Massachusetts of a girl who was bullied at school. She broke up with a boyfriend, and this gentleman, this boy, and a group of girls bullied her for over a year. And then she killed herself. And this particular gentleman who bullied her was just arrested for a sexual assault on a college campus in Massachusetts, in the same town that happened, I think, 10 years ago. But each day, 160,000 kids in the U.S. refuse to go to school because they dread the aggression of their peers. Bullying, the use of force, threat, to abuse, intimidate others. This really traumatic story, I think it was a month ago. Boy 10 kills himself after being bullied for wearing a colostomy bag. Bullying and suicide. Um, so, medications, trauma. I want to kind of end tonight, and then we'll have plenty of time for questions looking at genetics. Our goal over these 3 hours is how can we develop a biological checklist when someone is at risk. And I just can't tell you how often we neglect, we as in the medical profession, neglect to understand or take a family history, in my term. DNA neither cares nor knows, DNA just is. We dance to its music, Richard Dawkins. Suicide, twin studies, adoption studies. There's a genetic heritability of suicide. These studies around 55%. And all I can say is, is this concept of taking a family history. This is our Hemingway family, and there were 7 suicides in 4 generations of the Hemingways. 7 completed suicides, not attempts. 7 suicides. I stress this concept of the family history to clinicians I work with. It's not asking, does anyone in your family have a mental illness, where you get a yes or no. It's a detailed family history. Oftentimes, people don't recall suicides easily or don't want to necessarily talk about it. You have to specifically ask, go 3 generations, ask for aunts, uncles, and relatives. And in my experience, there's often completed suicides in our high-risk kids. Family histories are really, really important. But, we know that genetics is that biological liability. It's not destiny. And there's this, beautiful term, epigenetics, where the genes can be turned on and off. So epigenetics is the studies that look at all these environmental factors that influence development, brain function, expression of genes, but doesn't alter the genetics. So social interactions, stress, learning, sensory experiences, and malnutrition. We can think of bullying and trauma and sensory deprivation and neglect and parenting, as well as malnutrition, all affecting these genes. And here's our nature versus nurture, because we can't really say that because nature can affect nurture and vice versa. So it's that dance between genetics and the environment. The term is, genes times environment. We're beginning to understand that. We have lots of old research that kind of disappeared, looking at those with certain genetic profiles, and their environment is different. They might have a stress or trauma, and those become high risk for suicide. Those without that trauma, they still have that genetic vulnerability, but they don't develop. And we've seen that with conduct disorder. The environment affects the genes for the MAOI. So this epigenetic has demonstrated in post-mortem studies to actually be a real factor in suicide. Here's a post-mortem analysis of brains of 46 suicide victims, looking at certain parts of the DNA and looking at methylation changes. And we're able to demonstrate that the brains of those that committed suicide had different um, uh, changes in a certain methylation profile in the hippocampus. For those of you who have not heard this concept of epigenetics, um, and particularly where methylation, so methylation is a important tool. It's just adding a group, chemical group, a methyl group, CH3, to the gene, and adding that methyl group has very dramatic changes to how the gene is either turned on or off. So these unmethylated um, genes you see on the top, the genes are turned on, and if we methylate it, add methylate it, we can turn off those genes. So turning on and off genes at certain periods in our life, and some believe there are critical windows for both kids and throughout adolescence, that some of these genes can stay turned on or off and can affect later development, later risk for psychiatric illness, and it's pretty clear later risk for suicide. There's a robust relationship between trauma through epigenetics affecting methylation of genes that eventually affect depression and suicide risk. It's important to understand that our genes can be turned on and off in milliseconds, right? If you're in your office and the fire alarm goes off, you're quickly gonna start shifting the synthesis of certain genes to follow that fight or flight response that's starting in that amygdala and that fear response. So some genes are going to be turned on, some will be turned off, but every kind of environmental experience is going to affect genes, some permanently, some temporarily. It's just a part of development and behavior. Okay, so we started this journey of a biological model for suicide prevention. And I kind of use the analogy of fire and these small kindling. And then as we add some of these biological risk factors, the fire is out of control. We talked a little bit about genetics and medications. Tonight, we talked a little bit about trauma, but the other variables we'll get to in the next two modules are going to be malnutrition that places the brain at risk for suicide, not suicidal thoughts, but completed suicide. We're going to talk about substance abuse. We're going to talk about inflammation, a little bit of what I shared with you in the trauma, and things like sleep deprivation. And the social media piece, we're not going to get to detail, but the term I've used is it's the kind of gasoline on this fire. We've also had in Massachusetts individuals, woman recently arrested for through texting, encouraging her boyfriend or friend at the time to complete suicide. He was texting her, asking her for help, and she replied, "Don't be a wimp. If you want to kill yourself, just do it." She was charged and recently sent to jail. So mental illness is a concern, and we can do better. Is clear part of the work that we've been trying to do. From a 90 million American, 1.7 billion people worldwide, and the fear is most people aren't getting help. Only 44% of adults are getting treatment, and less than 20% of kids receive the needed mental health treatment. So we can do better with depression, and certainly suicide redefined. The model that I'd like to kind of develop for you guys is looking at errors in physiology If we understand those biological risk factors, then we can develop a model for prevention of suicide. So these are my websites, James Greenblatt, Psychiatry Defined as a Professional program with some online courses, and low-dose lithium. We're going to be talking about in the next modules, looking at a suicide prevention intervention with nutritional lithium. In the orthomolecular medicine on their website, last year, isom.ca, we did a 5-module course on schizophrenia and psychosis, and this year on suicide prevention. So I will stop, and we will have time for questions.
Thank you, Dr. Greenblatt, for this informative presentation. Before we move to questions from participants, we would like to remind you that registering for the course will provide you with on-demand access to recordings of all 3 modules, a printable course manual in PDF format, and a certificate of completion. To register for this course, go to isom.ca, that's ISOM.ca, and click the Events tab. Now back to Dr. Greenblatt for questions.
Thanks. So for this particular module, I'm not going to be looking at heavy metals. In the depression and schizophrenia courses, we do talk about copper and lead and heavy metals as it affects mental illness, but not suicide in particular. I'm going to comment on the complications of some of the football players and Aaron Hernandez, and so I'm not going to comment on any of the specifics around that, what was suicide and what wasn't, but I appreciate that comment. But certainly making a point that brain trauma does affect inflammation and risk for suicide. Low birth weight, premature infants. And circumcision, I do not know of research with circumcision and increasing risk for suicide. Genetic SNPs associated with high risk of suicide completion. I don't think we have a genetic SNP associated with suicide, but we certainly have genetic testing that can help us understand biological risk for depression and poor response to treatment. So to me, those would be things like MTHFR, folate, TT variant, high risk of treatment refractory depression, other genes, serotonin transporter, a gene, poor response to SSRIs, and there is some literature, increased side effects. The suicide is unclear, but in my experience, those that have the SS short allele on the serotonin transporter, in my experience, often have had increased suicidal ideation on the antidepressant. There are a couple genetic, testing companies out there. I've been using Genomind for many years just because I like the report. A bunch of them have asked about CEU credits, and I'm not aware of that, but if you can just email the ISOM, and I'll make sure I find that out before the next module. Great question. When considering family history, is there a change in level of risk correlated with closeness or remoteness of relationship? And I don't know if I have research, but in my clinical experience, that it is not a direct correlation. Obviously, when a close relative, a parent, a loved one commits suicide, the emotional trauma is raw, and it affects every aspect of their being. The biological risks that I'm seeing, often it skips generations, it's aunts, When we talk about some of the other biological risk factors, one of them we're going to talk about is very, very low cholesterol, which I believe is genetic. Um, and that's why sometimes it skips a generation as to the severity of that cholesterol. What is opinion? Dr. Thomas Joyner, why people die by suicide. I'm not aware of that. And I've read so much about suicide, and those first risk factors that I talked about are so important, meaning loss and social isolation and medical illness. I mean, that list is long, and that's what we train our clinicians how to understand. I have not seen much written about these biological risk factors that, to me, would be added into our kind of psychosocial risk factors to develop a comprehensive kind of high-risk profile. Yes, we'll be talking more about inflammation. The actual blood test is a C-reactive protein, is a generic marker, but some of the studies on depression and suicide, higher C-reactive protein values increase risk of suicide. As the cytokines and C-reactive protein went up, suicide risk went up. Physical illnesses like meningitis affect long-term brain inflammation. Certainly, most of the brain inflammation we're hearing about is with Lyme and other infections. Some of our short-term viral or bacterial meningitis that resolves due to treatment. It is really unclear if there's chronic inflammation. Again, we do have markers that we can look at. I use an organic acid. One of the markers of neuroinflammation that I have found pretty significant is elevations of a substance called quinolinic acid. Quinolinic acid is in the organic acid urine test and a marker of inflammation in the brain. Certainly concerns about suicide postpartum. It's been written about a lot. And as someone mentioned, I was talking about how do we understand unresolved grief teased out as a factor regarding family history. And the only thing I can say is I think there's so many kind of psychosocial factors that do get passed on across generations. But in this biological model, again, oftentimes the individual we're sitting across from has no idea or have never met the aunt that committed suicide 20 years ago in another state. So the next two modules are at the same time, 8 p.m. Eastern Standard Time. The low cholesterol that we're going to talk about a lot under the nutritional risk factors for Module 2. The low cholesterol is not related to an eating disorder. Most of our patients with eating disorders actually have normal cholesterol or high cholesterol because they're under chronic stress. Our body makes a lot of cholesterol. So it's not our eating disorder patients. Low cholesterol appears to me to be this genetic difficulty. It's unclear what it is because it does run in families. And these total cholesterol numbers are 120, 119. We had a patient admitted to our inpatient unit that had a total cholesterol of 69. So really dramatic levels that are unrelated to dietary intake. And most of these very low cholesterol patients we're seeing are eating junk food and hamburgers and plenty of cholesterol. Um, okay. Again, the low birth weight is not anything I've read anything to worry about in terms of risk factors. Um, let's see. And then a bunch of questions about the registrations for Module 2 and 3. My understanding, because Module 1 was a free webinar, there is a charge, I believe, that you can get on the ISOM.ca website for Modules 2 and 3. So you need to go in and register and pay for that. So we'll stop here. I appreciate your interest. The next two modules will be a little more concrete. We're going to talk about nutritional deficiencies of cholesterol, omega-3, vitamin D, and how it affects the brain, which is 60% fat, and how these are simple blood tests that we can do for at our high-risk individuals. And then Module 3, as I described here, will go more in detail about the role of inflammation and the testing that we can do. And then my favorite topic, detailed about nutritional lithium and how we can use nutritional lithium to understand suicide risk and come up with a roadmap to prevent suicide. So thanks again, and if you want to see the next two modules, you got to register on isom.ca. Have a good night.